Sickle Cell Anemia Study Committee to order. My name is Ed Harbison. I'll be chairing the committee. I'm honored to have with me my colleagues and constituents of the committee. They are Senator Gloria Butler to my right, Senator Tanya Anderson, who is taking care of caucus business out of town. To my left over here, Senator Chairman Kay Kirkpatrick, and to my right, Senator Kim Jackson from the 41st. And we'll be hearing from them later on. But I just want to make some opening comments about sickle cell anemia. Over the years, I have been made aware of the efforts of a lot of people around the state of Georgia who want to put forth an effort to try to alleviate the pain and suffering and do something about the people who have to deal with this insidious disease. So it's touched a lot of families, and I'll say African Americans primarily. In our Columbus area, you have Miss Lois Jackson, Lois Williams. I'm sorry, I looked at Senator Jackson when I said that. We have Miss Lois Williams, who is a stalwart, a standout advocate for sickle cell anemia and its families and things to do to make it easier for them to get around. One of the things that I'm always hearing from her, and I'm going to talk to her about it when we get her on a Zoom call later on, is funding and access to medical care and that kind of thing. So we'll deal with that. So what I'll do, I'll start from my left and go to my right and have members of the study committee make comments as they desire. Then we'll get started.
Covet, Fulton, number 2. And I was very happy to be invited to be on this committee. As a physician, I've seen a number of patients, even as an orthopedic surgeon, who've been struggling with this disease. And so I'm very much looking forward to hearing the testimony.
Thank you, Senator. Madam Chair, Gloria Butler.
Madam Leader, thank you. Thank you, Mr. Chairman. Appreciate the fact that you have pulled this study committee together. For those in the audience, I'm Gloria Butler, Minority Leader of the Senate Democratic Caucus, representing parts of DeKalb County and Gwinnett County in District 55. And I just want the committee to know, in the past, I did a little work on sickle cell and made it possible where the newborns would be tested for sickle cell. And so that's been, I'm sure, very helpful. It's been such a long time ago. I can't even tell you what year it was, but it was in addition to what the state can do for our newborn babies. So thank you, Mr. Chairman, for bringing us together.
Well, thank you very much. Senator Jackson.
Thank you, Mr. Chairman, for including me on this committee. My name is Senator Kim Jackson. I represent the 41st district, which abuts Leader Butler's district, DeKalb, and Gwinnett counties. I'm here in part because my family has been deeply impacted by sickle cell disease. A number of my aunts and uncles and cousins suffer from this disease. But also uniquely, my mother was the community health nurse for children living with sickle cell in South Carolina. And so for the vast majority of my childhood, I spent going to rural peach orchards and visiting with children who were suffering from sickle cell and helping transport them to the hospital and being with them in crisis. And so my entire childhood was shaped by standing alongside my mom as she nursed that community. And I have a deep compassion and deep place in my heart for making sure that we care well for all who are living with the disease. Well,
thank you very much, and I certainly appreciate that. And I can see you there learning from the master's touch. That's right. Absolutely. We'll get on the way now. We'll start it off with Ms. Jamila Pope, who will introduce our speaker for this occasion. If Ms. Jamila Pope come in and bring our speaker with her. There we go, right there. How you doing? And adjust that mic as you see fit.
The seats are spaced out enough.
That's what I thought they said. So it would be
if you announce it.
All right, as they said, choose it out. Good morning, madam. How you doing? So far, so good.
Good. Well, thank you for having us today. My name is Jamila Pope. I'm the Government Affairs Director at Children's Healthcare of Atlanta. And as many of you know, Children's Healthcare of Atlanta is one of the largest pediatric health systems in the country. We see children from every county in Georgia. In 2019, we had more than 1 million patient visits with more than 400,000 individual unique patients. And almost 60% of our patients are on Medicaid. And relevant to today, we have the largest pediatric sickle cell disease patient population of anywhere in the country. And sickle cell disease is a very hard disease for the patients, for the families, and there's been a lot accomplished over recent years that have allowed for medical advancements and patient care, but there are still many challenges that exist. And that's why we appreciate your attention to this very important issue today. Today, I have Dr. Krishnamurti, who is a pediatric oncologist here with me today. He is going to tell you more about sickle cell disease and some of the advancements and challenges. Dr. Krishnamurti is an attending physician at the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta. He is the professor of pediatrics at Emory University and the recipient of the Aflac Field Force Endowed Chair in the Pediatric Bone Marrow Transplantation. He has more than 20 years invested in research of sickle cell disease, and he's truly an expert in this field. So with that, I'm going to turn it over to Dr. Krishnamurti.
Thank you, doctor. Good morning.
Will someone be advancing the slides for him, or
Say again.
his slides?
There-
There we go.
Okay.
Do you want me to advance?
I can do it.
Will you say your last name, doctor, one more time?
Sure. Krishnamurti.
I got to break that down, but thank you. I'm going to proceed. Thank you. I got it. Thank you. I didn't see it. Thank you.
Mr.
Please
Chair-
proceed.
Yeah, Mr. Chairman and members of the committee, I'm pleased to share with you some information and insights on sickle cell disease, and happy to take any questions from you. To start from the beginning, sickle cell disease is an inherited disorder of the red blood cell. And the red blood cell is typically donut shaped, like a donut that's filled in, and it contains hemoglobin. And when there is an abnormal genetic mutation, this hemoglobin clumps and distorts the shape of the red blood cell, and that looks like a sickle. And this obviously is not an advantageous shape for the red blood cell to roll along in the blood circulation. So essentially, it obstructs the flow of blood and causes an impediment to the delivery of oxygen, and oxygen is the gas that makes the body work. Sickle cell disease affects every organ. Some of the major problems are stroke, problems in vision, problems in cognition. One of the big problems is pain, both acute pain and chronic pain with acute exacerbations. Bone and joint damage that might require surgery. It might require dialysis or kidney transplantation because of renal failure. And unfortunately, individuals with sickle cell disease probably have a 20 to 30 year loss of life expectancy. So it's a very major problem, and they could die due to infections or cardiopulmonary complications. Just a word on the other big news that has been overwhelming the world in the last year is the COVID pandemic. So how does the COVID pandemic affect sickle cell patients? And based on what we know from registry studies and case reports and case series, there is an increased rate of severe COVID in patients with sickle cell disease. The rate of admission is about 60 to 70%, as opposed to about 17%. This is what we've learned from the registry data. The most common presentation in a sickle cell patient getting admitted is severe pain. The other major problem is acute chest syndrome. That's a lung problem due to sickle cell disease, or pneumonia. And especially in the ones that unfortunately die, that lung problem is often what is the final cause. And the death rate also is, compared to 1.75% for COVID overall, it's anywhere between 3.5% to 10% in the various case series. Patients with sickle cell disease are within the emergency use authorization to receive the antibody therapy as soon as they have COVID, so as to not actually get severe disease. Another issue is that that has been studied to some extent is a socioeconomic disadvantage that many patients with sickle cell disease have. So they are disproportionately affected socioeconomically. COVID vaccination rates, we all know the data for the different ethnic groups, overall, and this is the rate in Georgia. So that's something to be aware of for COVID for sickle cell. Sickle cell disease is a global public health problem. There are over 300,000 births of sickle cell disease each year, 4,000 of which occur in the United States, and disproportionately more than half live in the southern United States. And 70% of the patients nationally are on a government-sponsored insurance, Medicaid or Medicare, and the overall cost of care exceeds almost $3 billion each year. Sickle cell disease is a major public health problem in Georgia. As you can see, it seems to affect most of the counties, about 7,300 people with sickle cell disease. And Georgia is one of the top 3 in the country for the number of patients with sickle cell disease. The patients are 97% African American, and 1 in every 295 births in African Americans in Georgia is a child with sickle cell disease. So because of that, and because of the excellent care that has historically been delivered here in Atlanta, the Children's Healthcare of Atlanta has the largest pediatric sickle cell program in the country with over 1,900 patients. We also have the largest experience curing patients with sickle cell disease with bone marrow transplant, with about 128 transplants that we have performed here at the Children's Healthcare of Atlanta. Fortunately, medical advances have improved the outcome of patients with sickle cell disease. Patients are diagnosed with sickle cell disease as newborns before they get a chance to be sick, so that we can start them on penicillin and give them the vaccines to prevent pneumonia, which is one of the causes of death even in childhood. Now, for many years, we do ultrasound screening to look for risk for stroke, because stroke is the other major complication. And so you can start them on medications or blood transfusions if you have stroke. There are several new medications, fortunately, even within the last 3 or 4 years. And so really, it's a very hopeful time in sickle cell disease. And bone marrow transplant for selected patients and gene therapy that I'll touch on are other things that are available. So the first drug that was approved for sickle cell disease is Hydroxyurea, which is actually used as an anti-cancer drug. And this picture actually shows you what Hydroxyurea does. As you can see that here you see the cells that are sickle red cells. And this is somebody, and you can see there's not enough red cells. This is anemia. And here's a patient who's on transfusion, and look at the blood smear. There are a lot more cells around. They have this lovely, donut shape, and not fewer of these sickle red cells. So it's an orally administered drug, and it can cut the rate of pain crises and admissions by half, and improves the hemoglobin, and it may improve survival and reduce risk for stroke. So this is the first drug approved by the FDA for sickle cell in 1995.
So doctor, so the only relief in sight is the pain application, or the efforts to curtail the pain somewhat, is that right?
Well, pain is a very troublesome common manifestation, and the commonest reason for hospitalization, and is also a quality of life issue. But acute chest syndrome, pneumonia, is life-threatening. Stroke is also life and limb-threatening. So it improves all of that, but it doesn't make the disease go away.
I see.
So yes, and you're right that it ameliorates the symptoms.
I see.
Within the last 4 years, there has been a dramatic shift with the availability of new drugs. So for 25 years, we only had Hydroxyurea. And then the next drug that was licensed by the FDA is L-glutamine, and it protects red cells in sickle cell disease. And in the same week in 2019, we had 2 new drugs, voxelotor, which prevents the clumping of hemoglobin, and then crizanlizumab, which again is another way you get a shot every month, and it blocks the sticking of platelets and red blood cells and white blood cells to the lining of blood vessels. So taken together, these drugs have the possibility of reducing pain and increasing the hemoglobin and improving the quality of life. They don't take away the disease as such. Another treatment with the cure, the intent is to make sickle cell go away and for people to be able to live without taking medications long-term is called bone marrow transplant. Essentially what we do in bone marrow transplant is we collect bone marrow we give chemotherapy and wipe out the bone marrow. So the bone marrow is what makes blood. And so we collect bone marrow from a donor. Your best donor is a sibling, and only 1 in 4 siblings is going to be a match. So practically it's going to be 15% will have a donor. And so you basically give them take the bone marrow from the sibling donor and infuse it. And then obviously this is a patient who has no bone marrow, which is a very dangerous condition. Also this bone marrow's, it's somebody else's cell, it can attack your body can attack that. So there's a prolonged period of immune suppression and a lot of expert care. And if we all do that, then there's a good chance that these people can then live a life free of the suffering from sickle cell disease. So that is a potential for some of the patients, not for everybody. It is a very complex decision making to offer a treatment like this, because on the one hand, this treatment can cure you of sickle cell disease. You have a potential to live without the complications of sickle cell disease and potentially live long. On the other hand, this is a risky treatment. There is a chance that you could die because of the treatment. And also there's a lot of treatment related complications. And so could you potentially be worse off from whence you started? And then as we do new treatments like cancer, we cure cancer, and then years later we find out that there are late effects of this treatment. So that is all being studied, but obviously as somebody, a parent making a decision has to take all of this into account. The other issue is age. If you do the transplant at a young patient from a sibling donor, the outcomes are a lot better. Like a lot of things, as we go on in years, it's more difficult to do. If you have a donor, it's easier to do. Very few have the donor, but we're doing now transplants from unrelated donor to national registries. We're doing it from parents, half matched. So there's a lot of research going on. And all of this is happening in the context of all of these other medications that are available. And you say, should we do this? Should we do this? Should we do that? So we have multiple choices and it is complex. Yes.
Senator Jackson.
Thank you. Can you speak to the efficacy of those medications over time? So do they become less effective if a patient is on it over time, or do they kind of maintain, or does that vary based on patient?
Sure, that's a great question. The short answer is we don't know because as I told you, the date when they were approved. But unlike antibiotics, we don't think of them as becoming resistant, right? But it also depends on when you started. So if you started when somebody is already so far out with so many organ damages, psychological, neurological complications, then you have a higher, more higher hill to climb, if you will. And then it doesn't take the disease away. The disease is still there. So, but that's a great question. Thank you. So I'll finally touch on gene therapy. This is an experimental technique, but it's being in human clinical trials. So we all make hemoglobin, the protein inside the red cell, because we have a genetic code which tells us how to make that. So therein lies the rub. There is a genetic mutation that makes us patient with sickle cell make abnormal hemoglobin. So what if you can correct that genetic mutation? That's the holy grail. And so we're approximating that by couple of ways. By creating a gene in the laboratory and taking blood-making cells from the patient and putting this gene into the cell, and then giving chemotherapy, wiping out the old marrow, and infusing this back. There are other ways is you can knock out a gene because no gene lives in isolation. And so there are other genes that are regulating it. So we can knock out another gene, wake up a gene that was sleeping that will make fetal hemoglobin and actually ameliorate disease. So these are now currently in multiple clinical trials at this point. These are early. So this is a picture that just shows here's a patient with sickle cell disease. And so what we're doing is, so we're collecting his own or blood cells. We give a shot and get the blood making stem cells to come out into the circulation. And we'll connect him and hook him up to a machine like this person. And then we send it off to the lab. And here we have this normal beta globin gene, and we're putting it in here, and it's cultured here, and then it's sent back to the patient. Meanwhile, patient gets chemotherapy, gets his new cells, and the new cells now make new blood. So this is also something that we're doing here in Georgia. So this is cutting edge, and this is all happening right now.
That's awesome.
So clearly, there's a lot of things that are happening in sickle cell disease, and I'm really proud to be working here, living in a city like Atlanta, which attracts sickle cell patients to come here because they know what is there, because it has programs with a large number of patients, very organized for many decades. There's a lot of community-based organizations which are extremely critical in having the patient's voice heard. There's a large number of research projects and a lot of funding from the NIH, CDC, HRSA, PCORI, a lot of clinical trials. We have the largest experience with bone marrow transplant, now gene therapy. Several studies are ongoing. But unfortunately, all of this is happening in the context of the old problems that still exist. Most of the patients in this period of observation of 3 or 4 years have been to the ED or hospital. And this problem gets worse with age because you accumulate organ damage, psychological damage, neurological damage of every kind. Adults have many more ED visits. And then adults have barriers to access to insurance, access to quality of care. And also this is all happening in the context of when they're no longer have their mother there to make sure that everything actually works out well.
Is one of the barriers pre-existing condition? Is that one of the barriers?
So the majority of the patients are on Medicaid, so they may not be able to.
Okay.
Yeah. So, and they may not be able to go to a hospital where there's an expert in sickle cell disease. They may not have the psychological, care that's really important because it's just not reimbursed. They may not have case management. They may not have access to bone marrow transplant, blood transfusion, the latest drugs. So access issues are really quite comprehensive in this population.
I'm interested in one thing before you continue, Doctor, and that is the ability of the average parent who has a child or that parent himself to be treated in whatever part of the state they're in. It access to care, I guess is when I've heard this from Ms. Lois Williams and other people in the sickle cell arena about the ability and access to care, blood treatment, that is blood tests and those kinds of things. So where are we with that across the state, and what do we need to do to correct it if it needs correcting? What do we need to do?
Absolutely. It is a huge issue. I think that recognizing that, socioeconomic deprivation acts in, and, health inequity works in many complex ways is, I think, our first step. I think that we're doing a lot with telemedicine. I think that especially our programs in Augusta are doing that. But we still don't have access to behavioral health. People who are over 18, finding insurance is an issue. The reimbursements, are a problem. Supportive care, case management. So it really comes down to basics. Again, paying for reimbursement for procedures, whether it's MRIs, pulmonary function tests, reimbursement for bone marrow transplant, gene therapy. So it's at multiple levels.
That state or federal you're alluding to, the repayment. Is that state or federal you're alluding to?
Yes.
Yes, state. Payment,
Well, ultimately,
Timely
it
payments.
comes to Medicaid is administered by the
Medicaid, yeah,
state.
okay.
And I'm not an expert in this area.
all right,
so
okay, I understand.
Yeah, so, but
So,
to the extent that
Medicare,
for the
okay.
last 2 decades, 2.5 decades, I've been working in this. So.
But let me just see if I can clarify for a moment. Most of our kids, though, that we're seeing, they're getting what they need, right?
So I think I was addressing the senator's question about the statewide, right?
Okay, yeah.
So there's
I
not
see.
taking anything away from the fact that here in Atlanta, we have a comprehensive sickle cell program that's the largest in the country. And I wanted to be sensitive to your question, which was about.
Yeah, and I appreciate that. And Columbus, Macon, Augusta.
Yes.
I'm just really concerned about
Yes.
access for people in our those medium-sized cities. I mean,
Yes.
it really is a problem, and we feel it because we represent those people.
Correct.
So we want to make sure. I applaud what you're doing in Atlanta. I mean, that's great, the largest. But some kind of way, I just feel we need to get some help spreading that out, and I'll let the people who work in that area speak to it. But that's just my personal take on it.
No, I got that exactly. Exactly right. And it starts right from the beginning because we are picking up all these people from newborn screening. The support needs to start from day one. And I think that as a legislature, supporting newborn screening follow-up, I think that's a huge part of it.
Thank you.
So we have drugs, but people don't necessarily take them. Here in Atlanta at CHOA, we've done a lot of quality improvement. Nationally, less than 40% of the patients have a prescription for hydroxyurea. We're probably 68%, so I think that these can be fixed. People don't often take the pneumococcal vaccine. Again, all of this goes back to access to care. We can screen and prevent stroke, but people are not getting all of those things. So I think, honestly, I've been working in sickle cell for many years. The access to care is a huge problem.
Senator Jackson, question.
Can you speak to where the breakdown is in getting that care? So a newborn is diagnosed as having sickle cell disease, then the next course of treatment sounds like they would need to get a vaccine for the pneumonia. Are the parents not being informed of that from physicians who don't have experience with sickle cell disease, or parents opting out? Like where is the breakdown in terms of newborn follow-up care?
Sure. So the breakdown, if you look at health disparity, right? Health disparity occurs at multiple points, right? So first of all, just distance from a center, like physical travel, the socioeconomic burden that they're already facing, the kind of care that they're already getting, the access to primary care or not. So then it adds up, it starts from there. So we may have all the information, but they have difficulty accessing that. The help to actually get them to care, case management care, often it starts in a mother who hasn't finished high school. You start right from there. There are psychological problems that's already existing in the family, but we can't get them to any of those and stuff. And then, of course, health insurance. Those things.
All right. Doctor? Okay. Are you
Go
ahead. We'll wait for the rest till you finish.
Go ahead.
Dr. Covet. Yeah, Chairman, you too. Go ahead.
So I second what you said about Medicaid reimbursement for providers. That's a access problem throughout the state. And we've known that for years. It's just hard to get there. I wanted to ask you a couple things. One is if you could just give a little more information about the genetics of this, how it's passed along between generations. And then also on the medical management, I'm sure hydroxyurea is off patent by now, so it's probably not very expensive. Is that something that you leave people on long-term, or is it episodic, or how does the medical management before you even get to a bone marrow transplant work?
So genetically, all of our DNA exists in duplicate, right? So from dad, from mom. And the piece of the DNA that codes for one protein is called the gene. And there is a gene that has the template, the stencil for making beta globin. So this beta globin gene makes beta globin protein and alpha globin protein, and heme join to make hemoglobin. So when you have a typo, one letter out of place in the beta globin gene, then you make abnormal beta globin and therefore abnormal hemoglobin. Because we have one copy from dad and one from mom, if one is okay, then about 40% of your hemoglobin is not normal, but 60% is, and it's fine. So that's called a sickle cell trait. And people may carry sickle cell trait and never know that they carry sickle cell trait. And they could tell you, sickle cell doesn't run in my family. But when two people who have sickle cell trait come together to make a baby, then there's a one, it's a scramble, and there's a 1 in 4 chance every time you make a baby, then that baby will have sickle cell trait. As far as medical management is concerned, it's comprehensive care. That starts from the time the baby is born, start on penicillin, making sure you get the vaccine, making sure the family is getting prepared for this long haul that they're looking at. And then age 9 months, we now start hydroxyurea, and you stay on it the rest of your life is what it is. So, and then it's obviously a drug that has to be monitored. So which means that somebody has to prescribe it. You have to be able to come and blood test. And so it's a significant burden of care just to take the medicines. And it's very difficult to take a medicine for the rest of your life on an everyday basis. Does that answer your question? Okay. And then, I think we've talked about most of these things. Another big thing is funding at every level, federal level, foundation level, for a disease such as cystic fibrosis is probably many-fold what there is in sickle cell disease. And again, I think that this is another way that this health inequity and health disparity happens. So if you, with your leave, I'll just summarize that it's a major public health problem in Georgia. We have a lot of things that we can do and are doing, and I'm thankful to be in a place where all of this is happening. But this is still a problem. There are all these new drugs. We have bone marrow transplant. We have gene therapy, but we're still stuck with access. There's, I think, supporting the community-based organizations to educate people, to empower them, and to be aware of their genetic risk is also really important. Lacking behavioral health resources is a serious problem. And we already talked about access to care. So thank you very much. Yes.
For your input to this very, very important issue. It's a medical issue that I've been had in the back of my mind, but it was snatched to the forefront every time that my advocate in Columbus always come forth and just in your face in a good way to make sure that we look at it and try to do what we can to help people in that
Thank you. Thank you for having us today.
Thank you. Appreciate you.
Right.
And also, I'm just really appreciative of your work with children with cancer. I had a nephew out there, and you guys did a great job on him. He was only 9 years old, but great. We're doing a great job. He's doing okay so far.
Thank you.
Thank you. Appreciate it.
Thank you.
Our next guest will be Miss Susan Shows, Georgia Research Alliance. Miss Susan, come in. How you doing? You're the go-to person now, right?
That's what
That's what he told me.
I like that. Good morning, Mr. Chairman and members of the committee.
Good morning.
I'm Susan Shouse. I'm with the Georgia Research Alliance, and I am very, very pleased to be here with you today. And I just have some slides to share with you. If you're a visual learner like me, I have to have things on a piece of paper. Now let's see if I can make this happen. There we go. Thank you for letting us join you today. We are very, very excited about the opportunity to partner with you on what is really a terrible, terrible disease. What I want to do today is give you an update on how our sickle cell disease initiative got started, what we've done so far, and then what our accomplishments, what we want to accomplish in this next year. So first, just a reminder of what GRA does. We have been around for 30 years, and we have been partnering with you and your fellow members of the General Assembly all of that time. And with the governor's office and with the business leadership in the state. So thank you for all of your support for those years. We have invested nearly $700 million of state money in the university research enterprise in that time. But our job is to strengthen the research capacity at the state's leading research universities and ultimately to boost the state's reputation as a great place for science and innovation. How do we do that? Well, we recruit outstanding scientists to the universities, and they lead big programs, big research programs. We outfit their labs with the most sophisticated equipment that's available to do that research, because winning big research grants is a very competitive business. And let me just say something about that research infrastructure that we invest in. The people who started GRA were very smart in coming up with this idea. We don't fund research. We don't pay for the people who do the research. The federal government does that on the grants. The foundations do that. Industry does that. What we do is provide the tools that allow them to do that research, because none of those sponsors will pay for tools. But that's how we can make ourselves more competitive compared to other states who are trying to compete for these grants. But what we've done, we've recruited 75 of what we call eminent scholars. These are the people at our universities that lead the research programs. Last year, they brought in something like $688 million in research funding to the universities. That's like a good-sized industry in this state, or a good-sized company when you think about it. Lot of economic output from that. The other thing we do, in addition to investing in scholars and their lab equipment, we help build companies around university discoveries. A lot of technologies are just kind of laying around in the labs. Faculty don't know the commercial potential of their own discoveries. Somebody has to get in there and help them with that. And that's what we do. And today there are 200 early stage companies that have come out of our universities, and we invest in any faculty member in the state of Georgia, public, private, college, or a university. If you have an idea, we're happy to work with you. But most of our ideas do come from the research universities. So all of this has generated great return for Georgia's taxpayers in the form of all of these research grants, the jobs created in the universities, the business activities of the startup companies. And I have to say that our universities and our companies are very appreciative of the state's investment in these programs. So now let's move to our sickle cell disease idea. And it really came from a program that addresses another serious health concern. Do you remember in January of 2020 when Governor Kemp announced that he was going to invest in a new endowed chair for Parkinson's disease, and he was going to name it in honor of the retiring U.S. Senator Johnny Isakson? Well, that chair, it's a new chair. It's housed at the University of Georgia, and it is named for Senator Isakson. The governor put $500,000 into his budget. UGA and Georgia Research Alliance raised the rest of it, and we recruited this outstanding gentleman. His name is Anu Kanthasamy. He arrives in Georgia next month. He will be the very first Isakson, Georgia Research Alliance, eminent scholar in Parkinson's disease. And I think he's going to be a tremendous asset to the state. He's going to make enormous contributions to Parkinson's disease. I'm excited about him coming. But GRA said, well, let's use this model to come up with a plan for how we could create a program around sickle cell disease. Except we're going to create the partnership first. We're going to figure out who can help us commit to raise money, who can provide some funding, and then we're going to go ask the governor for help on creating that first sickle cell disease eminent scholar chair. So that's what we've done. We started out with three partners here: Children's Healthcare, Emory University, and Morehouse. And those are our initial partners. We're going to be bringing on other universities, other hospitals. I was in Augusta on Tuesday of this week, meeting with the dean of their School of Medicine, because they very much want to be part of this, and they will be. But the side benefits, some of the side benefits of this initial partnership that I think is so exciting is it's going to increase collaboration between Morehouse School of Medicine and Children's, between Morehouse and Emory, between GRA and Children's, and Morehouse School of Medicine will be able to get their very first eminent scholar via this program. And Valerie's very excited about that, of course. So already we have a minimum of about $16 million of investment committed over a 5-year period. Now you'll see that half of that is public through GRA, half of that is private. That public money we're going to need to raise from the state, and so we'll be coming to see you, because that's we have $500,000 in this year's budget. Okay, so $7.5 million to go for GRA, but job one for us is going to be to recruit this program director, the sickle cell disease program director. So who could be our Johnny Isaacson for sickle cell? Well, it didn't take long for us to think about our friend Calvin Smyrie, longest serving current member of the legislature, a very good friend of GRA and higher ed. So the governor liked the idea, lieutenant governor, the speaker, some of the legislative leaders we talked to, and we were able, because we were only asking for $500,000. That wasn't a real hard ask, and we did get that in the budget this year. There are other elements to this $16 million plan. There's going to be a second eminent scholar called the Aflac Teresa White Chair. And guess what? Aflac is paying for every penny of that endowment. We're not having to raise any money for that. We're very grateful to them for that. We want to recruit 2 what we call GRA Distinguished Investigators. One will be at Morehouse School of Medicine, the other at Emory. These are younger in career faculty members who are just wired to do translational research and clinical trials. So they're going to be a big asset to the program. But we think this $16 million program is really, it's just laying the foundation for what's going to be a much bigger program for our state, how we can become the national leader in sickle cell disease care and treatment. And we're going to extend it to other universities and hospitals. You know, the previous speaker mentioned some of the advances being made in care for sickle cell patients. And it is wonderful what's been made, but guess what? Those drugs are really expensive. And we want to plow ahead to say what other treatments and diagnostics can we come up with that are affordable and are accessible all over the state. And so that's why it's important. Even if a wonderful cure is found tomorrow, it's not going to treat everybody. So we need to be working on multiple levels there. But the next steps for us is we have a search committee formed. We're already meeting to look for the best candidate. And we expect that we're going to find a candidate by next spring. And then we're also underway now is a fundraising effort, because that $500,000 that the governor provided for us, that goes toward a $2 million endowment, a total endowment. And just so you know what that endowment does, right now GRA has 75 endowments across our universities. The state has put about $56 million toward those endowments. They're now worth more than $170 million. So when a faculty member in one of our chairs retires, we say, well, you know, good luck. we're going to go hire someone else, and we don't come back to the state and ask you for new endowment funds. We can reuse that. And those endowments have grown now, but we want to make sure we have at least a $2 million endowment for the new sickle cell Calvin Smyrie chair when that person is recruited, because that'll be a very competitive endowment. It creates proceeds every year, the interest off of that endowment. And what our scholars typically use their proceeds for, they hire someone who their grants won't pay for. And so it creates another job, if you will, in most cases. So some of you were in Columbus when the governor announced the Calvin Smyrie chair. It was a great day for Calvin and for GRA too. We were just tickled. We had been sitting on this secret for so long, and we were really pleased that we were able to do that in his hometown. So that's kind of where we are with our rollout. We want to have the Smyrie chair filled before we make a lot of big decisions about this plan, this program, because that the Calvin Smyrie Eminent Scholar needs to own that strategy and be in charge of that. A concern I have that I'll share with you. We are hearing that the budgets, the state budgets in the new fiscal year 23 are going to be flat. If that's the case, there's not going to be any money for research infrastructure for this program. That we have zero money in our budget if it's a flat budget for a sickle cell disease initiative, and that's going to make it hard for us to recruit the very best candidate for the Smyrie chair. And we won't be able to move ahead with some of the other elements of the plan. So I'm concerned, our partners are concerned, and we really don't have a plan B for now, but we are committed to try to make this happen as soon as possible. And I thank you for your time.
Yes, one question. I noticed you had two names up there, and you didn't talk about my Aflac company person of that, Teresa White, and I want you to give us some input about the program director and what role that will entail.
I'll be happy to do that. So the Calvin Smyrie chair is really going to be the program director, and that person will be an MD and will have a lot of clinical responsibilities. The Teresa White chair is going to be a research director, and that person will either be a PhD or a PhD MD in all likelihood. Probably won't treat patients like the program director will, but would be focused on leading a research program and working on getting these big grants to advance the discoveries.
Comments, members of the committee? Madam Chair?
It's not really a question, it's just about the budget. I'm sure you know that the budget is a process that only starts with the governor's office, and it gets beat up in many ways as it goes through the House and the Senate. So I do think it's always good to have a plan B, however, and I'm sure that you guys are already putting some thought in that. You obviously figured out that going to the private sector as a place to start was
Right.
good idea, and that looks like it's worked out really well.
Right.
So just, I'm sure you understand that the beginning of the budget and the end of the budget are two different things.
Right.
Thank you. Appreciate it, Madam Chair. Really appreciate your
Thank
time
you
and your
very much.
valuable information. Thank you so much. Next, we have by way of Zoom, Ms. Lois Williams, Association of Sickle Cell there in Columbus, Georgia. Are you with us, Ms. Williams? Can our tech guy give us some input on this? Where did he go? Oh. Give us a moment. Say again. Can you unmute yourself then, Ms. Williams? And I think he needs to be here.
Can you hear me now?
Go right ahead. You're loud and clear.
I can. All right. Good morning. If you can hear me, my name is Lois Williams, and I'm with the Association of Sickle Cell here in Columbus, Georgia, and I've been listening so far. And I thank you, Senator Harbison, for inviting us and including us in on this session today. And in your comments, you've already covered some of the things that are important and of primary concerns for us here in Columbus. But the Association of Sickle Cell Lower Chattahoochee Region, our organization here in this area, has been in existence since 1995. And we've had a slow start, and through the years it's been slow, but great news, we are slowly improving on what we're doing here, and very proud of the accomplishments that we have made. We follow the same area that the West Central Health District does in our mission and goals of our work here. And that is the 16 counties in the West Central Health District. We are very small, so we've not been able to do great outreach in all of those counties. And we primarily have focused most of our time on the 8 counties surrounding Muskogee. But in our area, that those 8 counties, very few of the other 8, have represented approximately anywhere between 350 and 500 people with sickle cell disease. We've worked closely with Georgia Health Policy on obtaining our numbers for what we are, our clientele in this area, but that needs more work too. And we are positive that it does not represent all of the sickle cell patients in our area. And a lot of that is due to the fact that because of the great work that's been done in Atlanta with the comprehensive care center, that a lot of our people go to Atlanta for their care. And a lot of times we lose them through those cracks because we don't even know that they are here. But that being said, we're doing what we can for those 300 to 500 that we do represent and that we get. So, in our work down here, we have tried to provide some services for our sickle cell patients. And back to the Atlanta part, we try to provide them with transportation there. Earlier, Dr. Krishna Murthy said that access to care is a big issue. That is the main thing, access to care. I would like to know if I'm still being heard. I'm getting some delay back here. Am I still being heard?
Yes, can you hear us? Okay. I don't know. Hold on one moment, Ms. Williams.
Am I still being heard?
Yes, yes.
Yes. All right. Thank you. Thank you. All right. The services, as I was saying, the access to care, because they do not get what they need here in our Columbus medical facilities, they seek the care that's in Atlanta, which that's primary for them. Of course it is. They need to go where they can get the best care. Protocols have not been established for our medical community to follow to how to treat the sickle cell patient. And that is they are very, very aware of that, all of our patients, and they do not like to visit the hospitals in this area because of that. Their treatment there, not only medically, but also emotionally, psychologically, they feel down on that area of care, that they feel they have not been treated correctly. We have lots of anecdotal stories, of course, to keep up with how they are being treated so that we can address this with the medical community here in Columbus. We've not made a lot of inroads on that issue at all. Everyone is aware of sickle cell disease, but how to treat it, what to do about these people that do not have money A lot of it don't have insurance. Some don't even have Medicaid, believe it or not. But we try to address that with them to help them get the help that they need. And also the social aspect of it because of their disability, and some of them lack of insurance. Now, all of them are not without insurance. Some have it. But because of that, they need access to other areas in their lives to improve the quality of their lives overall. So we try to provide some social services and using the resources in the community and what we can do in our organization. We do that to help them with housing, medications at discount prices of those kinds of things, utilities, and those life issues that they face because of their disability and lack of funds. So we do all of those things, transportation, care packages, and health education and counseling is a big, big thing here in Columbus, because we not only have to educate our sickle cell patients, we have to educate the public because of all of the things that have been misquoted, misstated, or not knowing just what to do about a patient that has this disease. It affects not just the patient, as we all know today, it affects families. So we're also not able to provide sickle cell testing out of our organization, but we partnership with the public health department here in our community, and we've been able to get them to start to do sickle cell testing on a discounted rate. They get about half price of what is usually customary for that test, and we direct our people to that. And once or twice a year, based on how much funding we have, we will provide certain days of free testing that we will pay for to get people in our community tested so they will know whether they carry the trait or have sickle cell in their families. So that's very, very important for us. And moving forward, I would just like to come out of all of this to improve the access of care in this area. The main thing is that they do not like to have to go to Atlanta. They know they have to do that because of the care that's there, but they want better access of care in their own communities. So I know that's already been stated, but I just like to drive that home here. My main reason for being in this meeting, and as we've talked continuously with Senator Harbison and with Representative Calvin Smyer, that we need funding to help us to do that in our own communities. We know we cannot do all of the things that they do in Atlanta. That is the Mecca, and we recognize that, and we help our patients to get there, but they want better care here. So I hope that what we come out of here will help Columbus and Muskogee County, but the other 16 counties in the West Central Health District, they need help very, very much. We also like to say this is a tri-city area. So we have a lot of people that come over from Phoenix City, Alabama, right across the river, that seek services here. I know they also get it in Alabama, and some of them do go to Birmingham for their blood transfusions and so forth, but they a lot of times come to us, and that's across the state line. And then we have to consider Fort Benning with Martin Army Hospital. The military people are not just on base, they are also out here in our communities. So Senator Hobson is very aware and know with our relationship with the military base that we are a tri-city area, and we'd like for Georgia Health Policy to consider that when they are compiling their statistics. So without any further questions, if you have questions, I entertain that. We do have a sickle cell clinic here. We have once a month visits from a doctor, a hematologist that comes down from Atlanta. And we want to thank the Sickle Cell Foundation of Georgia for helping us with the cost of that. But we are providing a sickle cell clinic once a month because we have no hematologists in Columbus that treat sickle cell patients. They are mostly treated by family practice if they do not go to Atlanta. So that's our spiel today. Thank you for listening. And if you have any questions, I would welcome that. Thank you.
Yes, thank you very much, Ms. Williams. And off the top, thank you for the work you do and the work you've been doing for years there in Muskogee County, and with the people like Representative Calvin Smyre, who is the chair of the research, and Teresa White, who's the program director. And then, of course, the assistance from Representative Carolyn Hughley from that area. I just want to say that we ought to be able to get some attention to some of the questions and comments and problems you outlined to us. With that, I'll go to members of the committee. Chairman Kirkpatrick.
Thank you. I guess sickle cell is not the only disease where we see a big change from what happens in the metro area and then out in the state. And that's a problem that we've been dealing with on many different diseases. So sickle cell's one of them. I guess I was curious about the role of public health and how just thinking out of the box about different ways to get protocols put in place throughout the state, whether it's through public health, whether it's through grants from them, or whether it might be through some educational efforts through the medical association. I think it would be useful to brainstorm some ideas about how to bring that quality of care out into the state from an educational standpoint.
Very, very good comments. Very good. Senator Jackson Butler in the comments. I think you're right on. I'm real interested in the fact that Ms. Williams said we have patients probably in Macon, other areas like Columbus, that have to travel to Atlanta in order to get sometimes the basic kind of care they need for that unique kind of disease, I suppose. So, but you alluded to it, that we need to take a look at it and try to figure out a way to, I don't know whether it's funding more, and I'm sure that entails it. I'm sure it does, but I'm really eager to research that and bring some remedy to that, real remedy, whether it's financial, whether it's healthcare personnel. And she mentioned they have no real doctor there, but one comes down once a month. Thank God for that. But I'm just saying, whatever we can do, I would encourage us to sort of put our heads together and come up with some solutions.
I agree with you. And it's not always money. Sometimes it's communication. Sometimes it's education, and who are the players who can help with that. So I'd be happy to work on that with you as far as communicating perhaps with the Medical Association and the Department of Public Health to see what role they might be able to play.
Absolutely. That is a great idea. Well, thank you very much, Ms. Williams. We really appreciate your efforts throughout the year. You do it every day, and we appreciate you, your entire staff, and your board. But thank you very much.
Thank you.
Want to make a comment before you leave?
Question around, I don't know enough to know how protocols are created and standardized, but it seems like we've got a lot of great experts here in Metro Atlanta who know how to treat people with sickle cell. And so it sounds like making those connections so that doctors in Columbus, even if they're family practitioners, they should be able to have some clear protocols in place. That doesn't sound like it should be that complicated, but I don't know how this actually works.
Yes.
Thing that
Dialogue.
I just thought of while we were talking is our medical education. We have medical schools in Georgia, and we have graduate medical education in Georgia, and there may be a role that they have to play on the education piece. So we should definitely look into that.
Yeah, I was speaking with Representative Smyre the other day about the fact that we have a medical school in Columbus, Georgia, opening coming up pretty soon. So that maybe we can sort of siphon off some of that and get some access that we really, really need. Any other comments? Once again, thank you, Ms. Williams, and God bless, and thank you for whatever you do. Yeah, thank you. At this time, we want to hear from Ms. Jocelyn Thompson and Carla Downs by way of Zoom. Jocelyn, is Jocelyn here? Jocelyn, come on in if you're out there. I'm sorry. But Ms. Carla is by way of Zoom. Can someone open the door for it? We got it locked out. Thank you once again, Ms. Williams. They probably can now, Danica and Jocelyn.
Good morning. Good
How you
morning, committee
doing?
members. Thank you, Senator Harbison, and thank you, Cindy, for allowing us to present today and join in on this important discussion about the needs of our sickle cell community. My name is Jocelyn Thompson. I am with Be the Match, the National Marrow Donor Program. I am one of the grassroots campaign managers on our state health policy team, where we focus on increasing health equity and removing those healthcare barriers for our patient population. I'm joined here today by my team member who's on Zoom, and I would like to give her an opportunity to introduce herself as well.
Good morning, everyone. My name is Carla Dawson. I am the Health Equity Program Analyst at Be the Match, and I do work on our Sickle Cell Warrior program. It's so great to be with you all this morning.
Thank you, Carla. So we would like to start our presentation off today by giving you a brief overview about who Be the Match is. So who are we? Our mission is to save lives through cellular therapy. And this is my cue. Here we go. Our mission is to save lives through cellular therapy. Authorized by Congress over 30 years ago, Be the Match, operated by the National Marrow Donor Program, manages the largest marrow registry. We help match patients who are battling sickle cell anemia and blood cancers such as lymphoma and leukemia with a donor. Many of these patients do not have a fully matched donor within their family, so they depend on the Be the Match registry to help them find a match. For most patients who battle these diseases, a bone marrow or a blood stem cell transplant is their only option for a cure. And our vision is to democratize cellular therapy to ensure that every patient, regardless of their race or ethnic background, has a chance to receive a life-saving transplant. As we talk about democratizing cellular therapy, it's important that we focus on diversifying the Be the Match registry. I'm happy to say that we've been focusing, putting a lot of resources here in Atlanta to partner with our state and local government officials, with our local civic organizations to do just that. For a Black or African-American patient, they have a 29% chance of finding a match compared to a white patient who has a 79% chance. So we have to increase those chances for our patients, and we're working on that. As we, in alignment with our vision to provide equal outcomes for patients, we must focus on our sickle cell community. And at this time, I'll pass it over to Carla to give us more information.
All right, thank you so much, Jocelyn. As you would have heard in earlier presentations, a stem cell transplant is currently the only potential cure for sickle cell disease, but so many disparities exist in accessing those treatments, and they exist for a number of reasons. It's a lack of awareness that transplant is an option. It's that donor availability issue that Jocelyn talked about. And it's a number of social, financial barriers that exist for sickle cell warriors just generally within the community. So our data shows that only 5% of individuals with sickle cell disease who complete a search of the registry looking for a match went on to receive a transplant in 2020. And that's an issue that we really want to work to address. So in order to do that, we underwent some research we call persona and patient journey research. And the goal of that was to understand some of the concerns of sickle cell warriors, understand the patient journey from diagnosis and beyond, and importantly, just to find ways to reduce barriers to transplant and other cellular therapies. So this was interview style and online immersion style, where we interviewed about 30 sickle cell warriors. And in case you're not familiar, sickle cell warriors is the term that many individuals with sickle cell disease use within the community. So it's a term that we use at Be the Match and in our programming. So we had online immersion sessions where people talk about their day-to-day life and what are the challenges that they face. We had really in-depth in-home interviews, 2-hour sessions going through the nitty-gritty of what your life has been up to this point. What do you think your future may look like? And then some co-creation sessions among sickle cell warriors where they were able to just feed off each other and talk about their needs and what an ideal state would look like in the future. Next slide. And from that research, we were able to find that sickle cell warriors are differentiated by 2 key factors, and that is potentially the impact of sickle cell disease on their life and their ability, and in some cases, motivation to manage the disease. And at the intersection of those 2 factors, 4 personas exist. And you will or have the slides in front of you, and I'm going to briefly go through each of the 4 personas. There's a whole lot of narrative on the next 4 slides, but I'm just going to focus on pulling out one key characteristic and one key need of each of the personas. Next slide, please. So the first persona that I'm looking at is the struggler. And a key characteristic is a life dictated by the symptoms of sickle cell. And that can mean that they're unable to work or access various resources that may be available to them. And a key need here is access to effective treatment and support for the daily tasks that may arise that they're not able to do due to the severity of their disease. And this is definitely like a high need situation, high impact, and low ability to manage the disease. Next slide. The second persona is the advocator. And this is someone whose disease does have a high impact on their lives, but they've been able to manage the condition fairly well as much as they can and advocate for themselves within the healthcare setting. Children often fall into this category because there's sometimes a parent structure to help advocate, and also due to the structure of the pediatric healthcare system, it's much better than adult care for sickle cell warriors. So a key need still for this population is educated providers who listen and who know how to treat sickle cell disease. In the past presentation, we talked about the fact that a lot of community referring physicians don't even know or have knowledge about sickle cell disease. So ensuring that we have educated healthcare providers about sickle cell disease and how to treat it. Next slide, please. So for our adapter persona, the impact of the disease is relatively low. And with lifestyle adjustments, they've been able to manage their condition without medication. Despite all that, there are still key needs, including awareness of treatment options, new research. They want materials to be able to explain their condition to coworkers or to healthcare providers and things like that. So even in situations where the impact on life is relatively low, there are still a lot of supports needed for sickle cell warriors. Next slide, please. And finally, the maintainer. The maintainer persona is someone whose symptoms are limited, so there isn't as much need for doctor's visits or resources. And it's really important to note that this can change at any time. So there's still a key need of assistance during a crisis and navigating the healthcare system. So we have these 4 personas, and they seem like pretty rigid, but an individual can rotate through any of those personas during any time in their lives. As disease severity changes, as they get older, or go from childhood to adult, you can see that people move into different boxes and their needs change. Next slide, please. So second to the personas research, we also wanted to look at the sickle cell disease journey from birth and beyond. And there are really some major milestones within the journey. And this journey lasts a lifetime and is often non-linear. So some of the challenges you face during the childhood day-to-day would also be challenges you face during a hospital experience. And these things can really compound on each other and be a burden for managing the disease. Next slide. So in childhood day-to-day, caregivers can face significant challenges. And initially, it's related to learning about the disease and figuring out which symptoms are normal for an infant and which symptoms have to do with sickle cell disease. It can be attending frequent tests and checkups and just navigating that whole system of now having a child with sickle cell disease. Life can also be really alienating for children. When they're unable to participate in some of the various activities, or if schools are sometimes unaccommodating to their needs. Symptoms can be highly unpredictable, so that can mean missing school or tests or assignments, and even things like missing birthday parties and not being able to live a normal day-to-day life. And one of the positive and great things we see in Georgia, because you do have a couple sickle cell disease camps, we've seen that they've proven to be a turning point for children. And it's really where they begin to get a source of support within the community and create their own sickle cell community. Next slide. So in the adult day-to-day challenges, we see again that same theme of living with unpredictable and potentially difficult to manage chronic pain and other symptoms. And these challenges span the spectrum of their life. So the financial challenges that occur from missing work, the emotional challenges of feeling misunderstood, and that combination of physical, financial, and emotional stressors can be a really heavy burden on an individual, as you could imagine. Next slide, please. And then finally, I want to talk about challenges during healthcare interactions. So many sickle cell warriors report facing racism, bias, and racial profiling during their healthcare interaction. I think this is especially true for emergency room services. They're often perceived as drug seekers. In other settings, they're being dismissed and not told about all their treatment options. For example, we know many times that individuals are not told that transplant could be a potential treatment option for them. Even for those who know about treatment options, there's limited support in accessing those options. And so when you pick something, for example, like transplant, there are a number of things that go into that. Mental health support that is required and fertility support, which currently there is very little resources for sickle cell warriors trying to preserve their fertility. And then lastly, there is a lack of consistency and continuity of care during hospital stays. Sickle cell care has the potential to be really disjointed. For children, we've seen that if you're in Atlanta, it can be really great. You're at CHOA and you get all your specialists, but outside of Atlanta, and if you're an adult, that really isn't always the case. Next slide. So using that research, we really wanted to inform a program here at Be the Match that could address some of those issues and provide resources. Next slide. So our Sickle Cell Warrior program really wants to increase access to treatment. And we're doing that first by raising awareness that a cure exists. And we're here to help you get to that cure if you desire that. To connect warriors to services to Be the Match, and I'll talk about those on the next slide. And then finally, a part of pursuing cellular therapies and transplant is getting HLA typing. So we're offering free HLA typing to sickle cell warriors and their families in some of our target markets, and Atlanta is one of those. So that'll be available for sickle cell warriors in Atlanta. And then we have our warrior package on the right of the screen. And this is a really educational outreach package that talks about your treatment options, not just transplant, but medication trials and others. It talks about the resources available at Be the Match, and then it connects you to your sickle cell organizations at the national and local levels. Next slide. So our patient programs at Be the Match really try to provide a wraparound service. So we have our patient navigators that work to provide emotional support and educational support to anyone calling in to Be the Match and connect them to resources outside and within Be the Match. We have our counseling services because we know that mental health support was something that was listed as a key need across personas. We have our Pair Connect program where people who have already gone through transplant are trained as volunteers, and they can talk to people who are thinking about it, may have questions, and just want to relate to someone who can understand this journey. We have financial assistance available for those who are pursuing transplant because even with insurance coverage, we realize there are a lot of costs related to procedures such as that. And then finally, we have our clinical trial search and support because we know that transplant won't be the best option for everyone with sickle cell disease, but we still want to support you in any way we can. So we connect you with medication trials, pain management trials, gene therapy trials, whatever it is that you need, we're here to help you to get to that. Last slide. So as we wrap up, I just want to pull out some of the key things that we found from the research. That sickle cell warriors face a variety of challenges throughout their lifetime. We know that their social challenges, support challenges, and the impact of their disease and their ability to manage can shift throughout the years. What your sickle cell look like at age 5 might not be what your sickle cell looks like at age 20. And so we need to have supports available at each stage of the sickle cell warrior journey. So many barriers exist in accessing care, particularly cellular therapies such as transplant. And so we have the opportunity to raise awareness about that and work to reduce those barriers. And then finally, sickle cell warriors need consistent, holistic, patient-centered, and appropriate access to care. We see how different the disease can be for individuals, and really recognizing that and catering our care to ensure that it looks like what it needs to look like for each individual. I think there's so much opportunity in the United States and right here in Georgia for us to make significant change for the sickle cell community. So if you have any questions, you can ask right now, and there's my contact information if you want to reach out later.
Thank you, Mayor McCall. You through, Ms. Thompson?
Yes, I
All right.
thank you.
Well, thank you, and you have, we do, excuse me, she won't let me finish. Let me let my leader right here. Let my leader ask a question. Go ahead.
Okay.
Senator Butler.
First of all, I want to thank Jocelyn for joining such a great program. And I don't know that everybody knows that Jocelyn was one of our sisters in
That's
my
right.
suite,
That's right.
and for years did a great job. She not only worked for the person she was assigned to, but she worked for me too.
Yes.
And so I really appreciated her all during the years that she was there. And I'm excited about what she's doing now. But I just wanted to ask, you said that Blacks have 29% chance of finding a match as compared to 79% of whites. Is it because there are not enough people signed up, or they just can't find a match of the people that are signed up?
It's really awareness, and Carla could probably add more to this. It's increasing awareness about the need and how we are the cure for ourselves. So that's been our focus, going out into the community to just increase awareness, because a lot of people don't know that this is an option for a cure. So getting out in the community, educating our community about this is about joining the registry and how you can help save people's lives.
Yeah,
Carla, did
and
you want to add?
I would just add to that yeah, there's definitely not enough numbers on the registry of the Black and African American communities, and increasing those numbers would do wonders. Just having being Black, having a diverse ethnic background, it does pose a challenge, but the more people we get on the registry, the more people will be able to match.
Any other comments, questions? Doctor?
Yeah, I think this is a dumb question.
Okay.
Probably not.
But in terms of screening for people to find out if they're a match, there's an increasing number of folks who are getting genetic screening kind of through 23andMe and other products like that. And I just wondered how the screening process works and whether anything like that would have a role to play.
Carla, do you want to take that?
Sure.
Ms.
So,
Some-
the way it works, it's not exactly the same as genetic testing. HLA typing is a set of proteins that do exist on your cells. And so we look for what those proteins look like and how they might match with somebody else. So you do a swab in them out and you return the kit and you're able to get those results later. I don't know how attaching it to something like 23andMe would work. I think there's a potential for some conflicts and some issues in there. I think we do have room to expand HLA typing for sure. And there's been work with a program called HLA Today to make sure that we're getting typing across the United States. But for something like 23andMe, I'm not sure how that would work.
Questions, comments? Well, thank you very much. You did a great job, and you brought your number one aide with you,
Danica
Ms.
Thompson.
Danica Thomas. And we appreciate you being with us, Danica, as well. You're on the case as usual. Thank you very much.
Thank you, everyone.
Thank you. Next, we'll continue through, folks, unless you want to take a break. We'll call in Miss Angela Snyder, Georgia State University. Angela Snyder. You got one by way of Zoom. Okay.
All right. Do I run the slides
You
of
good?
this?
You good?
Okay. All right. Well, I'm Angie Snyder. Hi. I'm from Georgia State University, as you mentioned, the Georgia Health Policy Center, to be exact. And we are I'm glad I get to play cleanup here because most of the other speakers have talked a lot about all the issues involved in sickle cell. And I'm here to talk about the data that's available in the state,
Okay.
because we've been working with a lot of those partners and we have a lot of data collected, and hopefully it would help answer any other questions you guys might have. So for those of you who don't know the Georgia Health Policy Center, we are a research center within the Andrew Young School of Policy Studies at Georgia State University. Oops. And we provide evidence-based research, program development, and policy guidance for a variety of health policy and health issues. We've been doing this work for over 25 years. We do have some work that's international, but we mostly work in multiple, over 1,000 communities across the United States, and a lot very focused on Georgia. So just a little bit about the data that I mentioned. So we have been working in Georgia with a whole bunch of partners, which I'll share with you in a second, to create the Georgia Hemoglobin Disorders Data Coordinating Center. So this work started more than 10 years ago in 2010. And if you paid attention to Dr. Krish Murthy's slides, I think some of his slides, a lot of the folks had slides that are from data that we've collected, but we've worked with a lot of these partners since the beginning, basically collecting public health data on folks with sickle cell disease from a variety of sources across the state, and put those together to try to help tell the best statewide story. And so most of these projects have been funded by the Centers for Disease Control, but they've kind of positioned us to get additional projects to study more and different issues with the sickle cell population. And I'll just mention briefly, just because the last speaker was talking about matching, the red hot projects that are at the bottom are more about blood transfusions in individuals with hemoglobin disorders. And it's the same kind of issue that you all raised about it's always easier match with blood if it comes from people of the same background. Mm-hmm. And we also have kind of a problem with our blood supply in that there's a lot more Caucasians that give blood, and they don't match the sickle cell population who needs the blood. They don't match the ancestries. And so there's different antigen patterns, and it's always better if you get an antigen pattern that looks like your antigen pattern. So we do work in that area too. So the project that I really wanted to talk about today is the sickle cell data collection project. The goal of that is to equip all these interested groups and individuals with reliable, actionable data and analysis for improving the well-being of individuals with sickle cell disease. And mostly we're talking about Georgia because that's where our data is from. But I realize, like Lois mentioned before, Columbus sits on the border of other states, and we don't have the data from any, from Alabama or South Carolina or anyone. And if you're a population center, you probably do have patients and people that migrate across. But we are working with the Centers for Disease Control, and I should say we are definitely out in front because we've been working on this for 10 years. It's us in California. And when the CDC gets additional data allocated, or not additional data, additional resources allocated, they're trying to spread this project throughout the country. And we are kind of educating other states on how to do this kind of data work. So Alabama is in the project, Tennessee is in the project, South Carolina is in the project. So in the future, I could see us doing some interstate collaboration. So what is in the data exactly? So we have data. We started in 2010, but we went back and collected historical data back to 2004. So we have data from all of these data sources from 2004 to 2019. It's statewide. It's as population-based as we can make it. It is individual level, and it does have identifiers. So that's why it's taken a really long time to get it, because we have to have data sharing agreements, because this is personally identifiable information. It's HIPAA protected data, but the only reason we have it identified, not because we're going to contact anyone, is so that we can deduplicate the data sources, because there's going to be overlap in these data sources, and we don't want to count people, one person 5 times, because we find them in 5 different data sources. So these are the data sources we have. We have newborn screening, which, as you all know, that comes from public health. And they do heel stick all the new babies born. They've only been doing that, though, for maybe 18 years or so, 16 to 18 years. So, I'm sorry, say that again? Yeah. So we only really have newborn screening data on people that were born in Georgia for the last 16 to 18 years. And so that doesn't count all the adults and anybody that was born elsewhere that has come into Georgia since they were born. We have Medicaid data. So we also partner with the Department of Community Health. We have the vital records or death records from public health. We have Children's Health Insurance Program data, so Peach Care data also from the Department of Community Health. We have some state health benefit plan data, and initially they were able to share the data with us, but we haven't been able to, when public health was more involved and they were leading the project. But since we haven't been able to get a new data sharing agreement, so we only have 5 years of state health benefit plan data. Hospital and emergency department discharge records that the public health department has, but the Georgia Hospital Association is the one that collects that information. And then we have clinical information. So we have sickle cell subtype information from the participating clinical sites, Children's Healthcare, Grady, and so that has in it Emory and everybody else. It's all the folks work together. We also have data from Augusta University and Memorial Savannah's pediatric program. So
Comment, yes,
go ahead.
Dr. Kilpatrick, please.
I'm sure you're very aware of the bill that we passed this year that authorized and is going to set up an all-payer claims database.
Yes.
And that's being implemented by the Governor's Office of Health Strategy and Coordination.
Yes.
That should really help you, I would think.
I have already been talking to the Georgia Tech folks because I know they're the ones that are kind of trying to set up the infrastructure and the governance of that. And yes, I don't know. We will have to figure out, because I'm pretty sure they will have access to the identifiers because they're setting that up. And then we probably won't. We'll have to figure out how we can work together, because that's the hard part is, people will share their data with you for a particular purpose, but if we start trying to share HIPAA data, it gets confusing. But I am well aware of that, and you're 100% right. I've been trying to weasel in and make sure that we're part of the governance structure, and that we help them with how they set it up and all that. So yes, that would definitely be helpful. This is kind of like a little mini project that is just of sickle cell that kind of does fit into a larger project. Okay, so you can imagine with all this data, we have access to, we have the incidence because we know the babies that are born every year, which is about 150 every year in Georgia with sickle cell. And the follow-up happens at Children's and also at Augusta. For the most part, I would say for 90% of the kids. And then we have the death records, so we can look at deaths. We have age for people. We have sickle cell subtype for the clinical ones and the ones that come from newborn screening. So we have a wealth of information.
Well, Ms. Knight,
Yes.
thank you. Can you sort of synopsize a little bit? We get running a little behind time.
Okay.
I
Sure.
appreciate that. We
Sure.
got one more presenter.
Oh,
that would help
okay.
us. But
Okay.
that data is really key, as Senator Kilpatrick said.
Okay, I'll try to speed up a little. These are all of our partners. Like I said, I won't go through all of them, but you've talked to several of them today. And these are some of the products that we've produced, a lot of different products for a lot of different audiences. You heard Lois say that it's helped her do the work that she does so well in Columbus. We've also shared it with the Sickle Cell Foundation, and they've done a lot of the training of the primary care docs around, and it helps them target where they're gonna do their work. Oops. These are just some other examples. And I will say that we have incidence and prevalence and like a lot of different types of data, quality data, like you heard Dr. Krishnamurthy talk about hydroxyurea use, how well that's happening in the Medicaid population, how well they're getting their vaccinations. I think one of you guys asked about that. Those kinds of questions we help different partners answer. And then there's a little bit about how we're trying to diversify the blood supply. So these, I think other folks showed these maps as well. So this is just a map of Georgia. It shows you there's only about 7 counties that don't have any sickle cell patients, at least not that we've been able to identify. And you can tell that the concentrations are in the cities, of course, and places where there's probably more people of color that would be in the target population. I just wanted to say this though, so about half those 10,000 folks are adults. And of that adult cohort, there's a combined total of over, so this is a pretty staggering number, 85,000 emergency department visits and almost 30,000 hospital admissions during that 5-year period for those individuals. And so that average is about 3 emergency department visits and 1 admission per person per year. So it's a very complex chronic disease, and even though it's not a lot of people, it accounts for a lot of healthcare utilization. And I think other people, you guys were asking questions about access, or everybody was talking about access. So those 2 yellow stars on top of the prevalence are the 2 comprehensive sickle cell centers, the one at Children's and Grady, and then the one in Augusta. They have both a pediatric and an adult clinic. And then those red stars, this is just for the adults. The adults have less access than the children do because there's just less funding flowing that folks can use the money for. Those other red stars are where the clinics, I think you heard, are held like once a month with a sickle cell disease specialist.
We got to get out of the red in those counties.
Exactly. And then I think also Dr. Krishnamurthy shared this, and he kind of explained why it's such an issue. So you can see in the younger kids, they're having some hospital and emergency department utilization, but it really kicks up when folks start transitioning to adulthood in that 20 and 30 year cohort. And that's about the time that kids are testing their boundaries, leaving their families, and the disease is starting to get more progressively worse. And a lot of folks are losing health insurance because most children have access to at least Medicaid or the state,
Okay.
the Peach Care
All right.
program.
Well, can you sort of wind it up a little bit so we?
Yes,
yes,
I've got
thank
one more
you.
slide. And then this one is just about Medicaid coverage. And there's about 56% of the population has Medicaid coverage total. And then you can see that it's more likely to have Medicaid if you're a child than you are adult.
Mhm.
And that's all I
Yes.
have.
Question?
Yeah.
Senator Butler.
I had a preface about saying I had a very good friend that suffered with sickle cell. He was from Nigeria. He went back to Nigeria because he didn't want to. He told me he didn't want to die here because it would be hard for his family to get his body back to Nigeria. And he did go back, and I think he passed last year. At the time that he was here and sick, there were periods when he had crisis. We knew then that the age was 40, a little above 40. But I noticed on these charts, you've got age up to 70. Has that extended over time because of treatment?
Well, I think,
other
yes. I think that is one of the things that we've found is, of course, kids are not dying as much as they used to because of the great comprehensive care they're getting. And there are some folks, and I think that you kind of identified a good research question, which is what is different, or how are some people living that long, or living into their sort of 60s? But I do know, I think somebody asked the question about other comorbidities. Basically, some people that are doing well end up pretty much, if you're in your 60s or your 50s, you start dying of the things that everybody else,
Right.
And I think that that's a problem, like to focus sickle cell doctors on these people they got other issues going on too of aging that everyone does. And so a lot of folks do die from complications of sickle cell, but they also die from complications of aging and other diseases that folks have. So yes, I do think people are living longer. And I think that means that you got to pay attention to their whole healthcare.
Yeah, I tried to get him to drink water all the time.
Yeah.
He didn't do it.
Well, apparently that does help, right?
Yeah.
Staying healthy and hydrated. So
Senator
He was
Kirkpatrick.
a
Oh, sorry.
patient. He was a patient at Grady. And so we started to work with Grady in their cell program. Forgot the name of it.
That
I
sounds
have
right.
a little plaque on my wall that has the name on it because we got money in the budget for their program over there. So I hope you have somebody from Grady come and talk to us.
Absolutely. Thank you. Senator Kirkpatrick.
This is just really a future research question, I guess, because I noticed that that sickle cell is on the list of conditions that can access medical marijuana.
yes.
And obviously that's not really an option right now because that's just getting cranked up in Georgia. But are you guys planning to look at that?
I know that I don't think that's on the list right this second, but I know that we did provide the Sickle Cell Foundation some information, data to help support getting them added to that list. Because I will tell you, that's a whole nother thing, and you can have other folks come, but getting access to opioids for people who actually need it is not easy.
Well, that was
There's a
really
lot of
my
places.
point is that
Yeah.
if a lot of those ER visits are because of pain, then other modalities, I don't know. I'm not very knowledgeable about the research in that area, but I do know it's on the list.
Yeah, and I think that's a good thing because of the opioid epidemic, there's a lot of places that just say we don't give
Yeah,
opioid
afraid of it,
prescriptions.
yeah.
And if you have sickle cell, you might need it in order to help me, help manage. So, all right, well, thank you.
Thank you very much, Ms. Snyder. I really appreciate your
And I'm
input.
willing, if
And
you all need any data to answer any questions that you have in the future, just let us know.
one quick question about coordination and availability of data, because you mentioned the kind of people sort of want to hold on to it. Do you coordinate with other agencies or?
Oh, yeah, we have all their data.
That's what I just want to make.
Yeah, and we
one of the
meet-
things people,
Yeah,
they
yeah,
don't
no,
talk
no,
to
no.
one another.
That's the whole point, is to get it out to
I got you.
everybody.
Okay.
So yeah, we have like, I would say meetings at least 3 times a year where we bring all the partners together and find out who needs what, and we try to provide it to everyone. So if
Senator
you all need
Jackson.
anything, just let me know.
Senator Jackson.
Actually, I mean, I'm going to bring in what has become a partisan question here, but would you all be able to find out if we expanded Medicaid, how many of those adults who are currently living sickle cell warriors, I learned that language today, how many of them would receive coverage from insurance? Because one of the common themes I've heard is that people lose their insurance coverage when they become adults. And so if we were to expand Medicaid to include basically the working poor, how many of those folks who have sickle cell would be covered?
I think we could do that. And I would say, it's funny, I'm talking to folks later today to try to do that in concert with the Department of Community Health. So we're not like, we're all on the same page with that. But yeah, I think we could probably figure that out. Some of them would be the kids that are transitioning that are not yet, if you want to call it, disabled, and they're not considered, they're not sick enough. Unfortunately, that's a terrible thing to say, but they're not sick enough, or they haven't shown sick enough to get adult Medicaid for disability.
Like SSI.
And then some of them would just be adults that are out there that, for whatever reason, nobody has picked them up and said, you meet the qualifications for disability. Let me help you get your Medicaid coverage. So yeah, I think we could probably do an estimate for that. And I would say that from what I know, because I'm sort of connected nationally, there are some federal bills that are circling around to potentially do demonstration projects through Medicaid where the feds would be willing to pay more of the share than they normally do. I think you asked a question about that, who's paying, federal or state? And Medicaid's kind of a shared program where the state has to give some and the feds give some. But in order to promote things, sometimes the feds give more share. And I think they've been talking about giving like 100% share for a demonstration. So if there's anything, that's a way to test something out to see if it's actually cost effective.
Thank you.
Any other comments before we go to our final participant by way of Zoom? And that is Ms. Deb McGee-McCrary, by way of Zoom, is the president and CEO of the Sickle Cell Foundation of Georgia. Are you with us, Ms. McCrary? She's not with us. Okay, I guess we had a little mix up on that one. I see that. Kenan Rogers, I suppose that's the tech person, I suppose. Ms. Deb McCrary, by way of Zoom, did we get a mix up on that one? Okay.
Excuse me, Jackie George is going to speak on behalf of Deb McGee-McCrary. She was not able to make it today.
Say that again. We didn't get the name. It was rather loud.
Jackie George is going to present on behalf of Deb McGee-McCrary. She was not able to make the meeting today.
Thank you, George. Whenever you're ready.
Good afternoon, everyone. Thank you, all of you, for, first of all, to say thank you for all the legislators have done for the sickle cell community in the state of Georgia. I just want to say thank you so much for all you have done. As an old saying is, you don't know a person until you've walked in their moccasins, and you haven't, but you've heard and you've listened to the sickle cell community in the state of Georgia. So I just want to say thank you. From the foundation, we have been involved with quite a few of the programs, with the Georgia Public Health Policy. We've worked with them, where you saw Ms. Angie Snyder presented Rush Project, the Fresh Project. We've been involved with all of those. Also, earlier when they spoke about the newborn screening program when it started, Dr. Nelson McGee was sitting at the table when they started the newborn screening program. Those talks started in 1979. The program with the newborn screening went in effect in 1980. And as they the gentleman talked earlier, from CHOA that it was to identify those babies at an early age that had sickle cell disease and to make sure that they were a part of the tertiary centers in the state of Georgia. But it also provided those parents that would be at risk for having a child with sickle cell, because those babies that were identified with having any kind of trait, the foundation since 1980 has been making sure parents know what their child's newborn screening results are, and to make sure that they are aware whether they are at risk for having a child with sickle cell disease. With our mobile unit that's been in place since we started in 1971, Mr. Harold Giles with our mobile unit has gone around the state, offered testing around the state of Georgia. At one time, it used to be in the school system, but things have changed so much. Like as Ms. Williams was talking about with the testing in Columbus, Georgia, we've done testing with our mobile unit. We take it down to Columbus, Georgia, and offer testing in Columbus, Georgia. We also, through a program that is funded by DPH to educate non-specialty doctors in the state of Georgia on how to take care of sickle cell patients. So Dr. Power and I call him Dr. Oakins, and please forgive me because I cannot pronounce his name, but they go down and provide these services in Columbus, Georgia, where there are no hematologists. They go down and provide that service. They also go in the Savannah area, and we're trying to go around to other places in the state of Georgia. We also, with the help of Dr. James Ekman, Dr. Power, Dr. Milford Green, also go, and with the help of Mr. Bernard Bridges, we go around and educate non-specialty doctors in the state of Georgia on how to take care of sickle cell clients. So we know that there is a problem with access to care. So we go down and make sure that those individuals have access to at least a hematologist. That is done with the help of our community-based, through the community-based organization, the CHWs, our community health workers. They will talk to clients, set up when a time and for them to come to those clinics. Access to care for adults is a significant issue for Georgia. We need better coordination between the clinical community and services, and access to primary care or taking care of those individuals. So we've got a lot of work still to do. As a community-based organization, we try to ensure that we listen to the clients. That's the challenge that we have, not only in Georgia, but around the United States. Individuals, healthcare professionals, across insurance companies, people do not want to listen to sickle cell clients. Who better understands disease than the client themselves? So if we start listening to clients, I think things will be much better off in the state of Georgia, access to care around the country, around the United States. And again, I just want to thank the legislators for listening to the sickle cell parents, to the clients, to the young people, when you invite us down to, when we have Sickle Cell Day at the Capitol, for all your participation, for even showing up in all your red. We really appreciate that too. So thank you so much for all that you do. And in any way we can be of any help to any one of the counties, please call us. Thank you.
Well, thank you very much, Patrick.
I had one question. I kind of missed what you said about the community healthcare workers. Are you talking about the federally qualified health centers? Because we have a whole bunch of those around the state that might be.
What we do with our community health workers, we have a program that's a prime example is in Savannah area. We partner with the federally qualified health center in Savannah, Georgia. We're trying to do that all around. We're making an effort. We made an effort to do that also in the Columbus, Georgia area, because we look at not only will we be able to have a specialty doctor that will go down and train, but all the other needs of the clients are taken care of, like OBGYN. Some of them have specialty doctors like cardiologists. They have dental programs. So that's what we tell our clients, to please go around, to identify with your federally qualified health center. That's been a goal of ours for quite a while. And we utilize our community health workers to make sure that clients are aware if there's a federally qualified health center in their area.
And you mentioned Columbus. What is the status of that one? I think you said you were trying.
Well, David, we had some problems with getting in some of the in that center down there. So we are still working on that. That's just something that we're trying to do. There were issues. Miss Williams, you want to address it? You need to unmute.
Okay, we're good. We're good. We'll discuss that. But we thank you for that input. I was just curious about that one point, and I'll follow up on it. Okay.
All right, we can follow up on it later.
Yes, sir. But like I said, we that's been a goal, because in the south part of South Georgia, where we don't have those hematologists and all, we're also trying to make sure that we tap into those federally qualified centers there. We're working with getting a community health worker in the Albany area and working on getting individuals with a federally qualified health center there. And where there aren't any federally qualified health centers, we're trying to connect with those individuals that do provide clinics and so in that area. Up in the Augusta area, we're working on that. Dr. Powell is working on that now.
Columbus didn't have space. We do have a partnership with them. They don't have space.
We do have a partnership in the Columbus area, but the challenge is, Senator Harbison, is they did not have space for us, for the CHW.
Say that one more time. They didn't have space for the.
We didn't have space for the CHW in their area.
We placed the CHWs inside of the FQHCs.
See, what we do, we try to place a CHW wherever we work, like in the Savannah area. We have a CHW there that works with their staff. We wanted to place a CHW in the federally qualified health center in Columbus, but they didn't have space for us.
I see. I follow you, and I'll follow
Yes,
up
sir.
with that. I appreciate it. I mean, you were clear. I like that. You were just to the point and very, very informative. We really appreciate your input. Okay.
Thank you so much, Senator Harbison. But again, you just don't know how much you all mean to our sickle cell community. We couldn't do it without you. Thank you so much.
Any other comments? Well, that's going to conclude today's study committee meeting, and I want to express unique perspective shared by members of this committee. We got a doctor, that's a plus. We got the leader over here can get the money for us, and got the one over here that can preach if we don't get the money that we need. But seriously, seriously, I want to thank everybody concerned. We're gonna ask everybody to get involved on this. I think it's worthy of the fight. In other words, I think the governor's office all the way down to the Senate, the House, and all of us involved, I think we can get something done to alleviate a lot of the problems across the state of Georgia. Staff, legislative council, and Senate research, thank you very much for being here today. If there are no comments, otherwise we stand adjourned. Thank you very much.